Good afternoon, ladies and gentlemen, and welcome to number 34 in the Royal Society of Medicine's COVID series by health professionals and for health professionals. So today we're going to cover the role of behavioural science during the current crisis. And could we possibly have better experts to talk about it? I doubt it. So our guest today, Professor Susan Michie from the Chair of Health Psychology at UCL. She was once at King's, but went to join the godless heathens to the north of us. Highly prolific across the whole field, 500 papers, manages to combine a great knowledge of theory with huge practical insights. Not surprisingly, she's been highly influential behind the scenes during the current crisis, a member of SAGE, a rather oddly titled Spy B, which no doubt she will explain, and on independent SAGE as well, and rarely off our screens. And joining her, Professor David Halpern, psychologist by background, moved into the murky world of policy, becoming Chief Analyst of the Prime Minister's Strategy Unit in 2001, and then Head of the Behavioural Insights Team in 2010, which he still is. I suspect, however, to his great displeasure, this is rather better known under the colloquial title of the Nudge Unit. So welcome all, and let's start with a straightforward, hopefully a nice slow full toss for you to dispatch to the boundary. Nobody doubts that behavior has always been the key to suppressing or managing epidemics. So if you were just to name, however, one really good example of how behavioral science intervention or insight, how has it proved its importance during the current pandemic, which would you both choose? Susan, would you like to start?
Yeah. I would say that the most important thing is actually, Simon, I'm not completely sure that everybody knows that behavior is at the heart of pandemics, and
they will when you've finished.
Reducing transmission. So I think the pandemic itself has demonstrated that. And I think there are two things that behavioral scientists have brought to the table in these short few months is that first of all, there's a science of behavior. Because, you know, I know that I can't build a bridge or perform heart transplants, but everybody sees behavior, behaves themselves, and everybody's got their own ideas about behavior change. And I think that what we have succeeded in doing, to greater or less extent, depending on the area, is demonstrate that it's a scientific subject. And the second thing, I think, is the importance of measuring behavior. That unless you know what people are or aren't doing with precision and according to different contexts, then we're not in a position to study it scientifically. And I think that awareness has been one of the things that I hope we're getting the message across.
Okay. David, what would you choose?
I mean, to echo on some of that, I think what it's really kind of come through is, you know, it's kind of behavior is really important. It's really important. It's your first line defense against, you know, an epidemic, you know, in relation to social distancing, hand washing, etc. In your terms, your second line, I'm sure we'll talk about that in terms of getting people to take a test, to get them to comply on self-isolation, let alone before, you know, what happens when you reach a healthcare setting. If I had to choose one example, at least, which is a good example of methods as well, is the early work we've done on hand washing. So there was quite rigorous trials, testing of refining of the message and the content to see what would cut through, what would draw people's attention. It's also got an interesting behavioural challenge, which is something which is not widely observed, seeing other people's hand washing. And so the work went into that about the 20 seconds, the design of the posters, not being too confusing, etc. Appeared to be highly effective. And if you, we have released quite a bit of that, you can see the iterations between the different designs to try and make it more effective. And then establish essentially a kind of a habit loop where you try and encourage people to get used to the habit of when you return to a building, when you return to home or you return to your office, then you actually wash your hands. It becomes a trigger. And it did appear to be effective, not least in terms of you can see actually other kinds of infection rates dropping over the period.
And Susan, at the same time, you were working on carrying tissues, for example. And again, it sounds fairly simple, but it's still worth explaining what the rationale for that was and how that works. Well, nice, uncontroversial and straightforward.
Actually, I wasn't working on that, Simon. I don't know where you got that from. But I will use the opportunity to just build on what David was saying, that it's not just about producing evidence very quickly now, but also it's looking and seeing what relevant evidence do we have that we can bring to bear on the table. So many years ago, during the Clean Your Hands campaign, which hopefully you'll have remembered, I was part of a team led by Sheldon Stone from the Royal Free, where we did a national evaluation of a behavioural intervention that was brought in on top of the Clean Your Hands campaign, which was based on self-regulation theory, the very simple idea that if people are given immediate feedback in the situation in which they are performing or not performing the behaviour, and get the feedback in relation to a goal they've already established, a sort of audit and feedback kind of cycle, then behaviour can change, even with these very routine automatic behaviours. It's not that they can't wash their hands, competing priorities. And that was written up in the BMJ. We showed that it was effective not only in terms of changing the behaviour, but also on soap and sanitizer consumption and on hospital-acquired infections. So we need to, having agreed that behaviour is central and behaviour is important, not just do very rapid experiments now, which is a good thing to do, but also look at what we know from decades of research in the past.
Fair enough. Okay, now questions are already flooding in, and I'm going to take a couple now, but I want to start really in a kind of almost chronological sequence, one going back to the beginning of the current epidemic. So now this time last year, nobody was worrying about COVID-19 because it didn't exist. And now levels of concern are very high. So that's clear. But what I want to ask about is, when this we started first talking about it, it was pretty clear that the public were not that concerned about it, unlike in some other countries, but it was compared with swine flu, which you both worked on and know very well that a lot of the protective behaviours weren't adopted because most people were not particularly concerned about it. How would you set about, or did you start to increase worry? Because if there isn't some fear, people aren't going to comply with anything, are they? So what do you think the role then, and Judy Oliver, in fact, has been asking about this, what was the role then of behavioural science in ensuring the public did start to take this seriously? Because without that, there's no chance of them complying with what might be sensible behaviours.
Well, there was very good evidence that people were extremely concerned after the powerful speech by Boris Johnson when we were asked to lock down, and we had mass, very sudden change in behaviour that was continued for quite a long time because people were concerned. But not only concerned, they understood what the concern was, what the nature of the risk was, and they understood the rationale for what they were being asked to do. And they also, at the beginning of any crisis like this, everybody wants to trust their leader. So there's very high levels of trust, which is incredibly important for adherence. So that's an example where actually people were concerned and behaved differently. Over time, what inevitably happens in any situation, you begin adapting to it. And that's gone along with various other things happening, like certain people not adhering to measures, also sort of more mixed messages. And so trust has broken down. People have adapted to the situation. People are being given signals as one opens up and lifts the restrictions. This is a very powerful message, almost back to usual again. So it's not very surprising that concern's gone down and, you know, in some ways, adherence. But
you're leaping ahead a little there, Susan. Let's just stick with the start.
Okay.
David, that initial period, though, you know, clearly there's a transition from no worry to worry. But do you think that we did enough or too much or whatever? Do you think it was necessary to see that level of anxiety rising before you could implement or recommend fairly firm measures to restrict liberty and what we could do? That was more what I was getting at.
Yeah. Well, look, first of all, you've got to even just break through, right? You've got to catch people's attention. They're busy, got lots of other things in their lives. So that's a pretty major challenge. This is going to be kind of broadband the attentional kind of channel. So what will break through? Concern, fear is not the only thing, but it clearly was relevant. And it was really important, as Susan was alluding to, that the the line we've always tried to go with is that you really want to be authoritative rather than authoritarian. So you try and give people an understanding it's actually based on something, good authoritative parenting, you know. So it has somewhere rational to go. And you can also understand, particularly if you understand the disease vectors, then you can start to make some judgments. However well specified, you know, guidance is, on the end, you want people to kind of actually have some understanding of the underlying etiology and adjust accordingly. So you really want that. I mean, look, I think you may be the psychiatrist here rather than me, but you, rather than fear leading into some kind of paralysis, you want it to be some kind of concern which goes to an adaptive behavior. So if all you achieve is fear, then that isn't getting you very far. But what you really want to do is break through and then actually say, what can you do about it? Give some sense of empowerment. So you going back to something simple like hand washing is that you're not just in the face of there's nothing you can do. There are actions you can take which will protect you, your family, and so on. And the same kind of carries on going forward. Even now, for example, around flu vaccine, people might be nervous. The flu vaccine won't directly help, it might help in some other way, but it also gives you somewhere to go with your concern. So you want people to calibrate their risk accordingly. They're clearly, in policy terms now, a very significant set of issues around the economic knock-on consequences, and behavioral economists particularly tend to study the issues around sentiment-driven, you know, depression and recessions, and that for pretty obvious reason, you can get caught into a vicious cycle. So how do you calibrate that right, the kind of right level of concern and so on? The last thing, just at least mention, is that it clearly becomes segmented. So there are certain sections of the population, so young men who might be like, you know, they're basically invincible, nothing's ever going to hurt them. Actually, in this case, directly, it might not hurt them very much. Versus other segments of the populations who've been essentially shielded, looking, you know, isolating very effectively, who, one question is, have they almost gone too far? We've reinforced a learned habit, which is every time you're concerned, do you now go home and don't go out at all? And then, you know, as in the development of the phobia, you actually kind of calm down, great. You're inadvertently reinforcing it. So there may well be some actual behavioral polarization occurring around these issues in the population, which we'll have to attend to.
Okay.
And also, Simon, if I can add here, that it's not just a question of fear, anxiety, and emotion to stimulate behavior change. So two things. One is that there's a really solid evidence that kind of threat is most likely to be effective if it's paired with and what you can do about it. And I think the power of this was that there was a very sudden emotional shock plus a very clear thing that you could do about it. So raising emotional levels on its own isn't helpful. And also there are so many other things that are helpful. So one of the strategies of you're doing this to help the NHS, to help your community, to help other people, very powerful. So one doesn't just have to go down the emotional route.
I think it was you who teaches and probably taught me that one should try and help people to know what to do, but not what to think or feel. No, I think it was you.
I'm sure I'm not responsible for that.
Well, okay. Now, Ian Harvey and several others have asked the question. I don't want to dwell too much on this one, but I think we need to touch on it. This is the thing that's going around that government were advised to delay doing things because of so-called behavioural fatigue. Now, which, as all of you and others as well have said, isn't really a scientific concept. It's not even clear who ever used the term, etc. But fair enough. But to put that one side there, would all of this have been avoided if instead of somehow getting into the language this idea of behavioural fatigue, we just simply talked about something very straightforward, which was how much pain can people take, behavioural compliance, behavioural adherence, all of which would have been non-controversial. I wonder, we just want to riff a little bit on maybe we ourselves or in this community got some messaging slightly wrong there. But behavioural adherence, what is the problem?
I think that one of the sorry, David, jump in before me if you want to. But
you've started, Susan.
Okay. I think one of the issues here is that over time, adherence can go down. Yeah. But the problem about having a thing that's called with a label behavioural fatigue, not only is it not a thing with no measures, no place in theory, etc., but it suggests it's an immutable thing that's always going to happen. Different sections of the population, as David mentioned earlier, have responded in different ways. And the key thing in order to maintain adherence is to really think about, well, a very simple model of behavior, which is behavior happens if people have got the capability, the opportunity, and the motivation. Now, we've been talking about motivation, incredibly important, but we do need to remember people's opportunity for staying at home. So there are very practical things about people's living environments. A lot of people are very crowded in inadequate housing, no access to outdoor space. A lot of people are in very low income and precarious jobs where if they don't go to work, they lose income and literally are struggling to bring food back to the table. There's still more than 1 million people who haven't had any financial help at all. So in understanding how to maintain adherence, and the same thing is now where there are localized restrictions, one's got to understand the different sections of the populations, the incredibly unequal situations that people are living with, and understand and address all of those, because if one intervenes in order to address the problems, then the adherence can carry on. So this idea that there's a kind of behavioural fatigue in your head that's going to kind of come out at a certain point, I just think is the wrong way of looking at it. Look at behaviour in its context, understand that and address that, and prevent what we know will happen if that's not done, which is adherence is likely to diminish over time.
David?
Yeah, so I think it's two questions here, Ron. First of all, what is this phenomenon? Does it exist at all? And then also, how does it relate particularly to any notions of delay? So is there habituation? Clearly habituation sometimes occur. And medics, by the way, particularly are aware of this because they know around medical compliance.
Indeed.
We did a big trial a number of years ago on tuberculosis, TB, which killed more than 1 million people a year, because basically people stop taking their pills because they feel better. So I think to practical, medics, they are very well aware of some of those compliance issues. And of course, psychologists see them too, get people trying to go diet, etc. It's effortful, things that, will sometimes habituate. But it's also true that sometimes behavior strengthens. Right? You can establish something we call a behavioral scaffolding, you get into a new habit, and then after a little while, in fact, it becomes really quite entrenched. And of course, there are clinical variations around this. So it clearly can go one way or the other. If you dig into the history of it, it is true that in the 1918-19 sort of second and third waves in US cities, there was some evidence that people stopped complying. By the way, they had nothing else to do then. You're supposed to stay at home in a really hot summer or whatever. And you don't have TV, you don't have internet. A lot of people couldn't even read often. And we're in a very different world today. So that goes into I think the second issue, which is that, to my knowledge, and people will call over it, but certainly we never, of course, gave advice on it, on this debate, given what we just said, and Susan will be the same. Spy B certainly wouldn't have been in a position saying, delay. We're not going to delay the measures on the basis of that literature. You should think about it. You should think about how you create the scaffolding and make it endure. But no. So I think it'd be quite good if we could just kind of kill that one on the head, and I'm sure future historians can try and work out where the word came from or not.
I think future historians are going to be very, very busy. Would just say what Spy B is. Not everybody would know that. So
Spy B actually, interestingly, stands for scientific. P is the pandemic, I is the influenza. And it actually was set up by me back in 2009 when I was on stage during the H1N1 pandemic. And I was the only social and behavioural scientist I think there were 14 scientists on the committee. And so I successfully made the case that we were so important that we needed our own committee. So I then established it back then. So the influenza, the I bit, has just hung on anachronistically since 2009. And I think it could do with a bit of a name change there. But it's a subcommittee of behavioural scientists to the Scientific Advisory Group of Emergencies that advise the government.
Okay, fair enough. And then in terms of names then, and name changes, this is one I think directed at you, David. Someone's asking about the ethics of nudge. I've slipped their name, I just missed it, but anyway. And, what is the ethics of nudge? And I think this comes down to when File on 4 were talking last week, one of the critics said it's wrong to see people as irrational beings who can be tricked or duped into doing the right thing. Now, is that a parody of what nudge is? or a real criticism?
Yeah, well, you mentioned at the beginning, I mean, slightly mixed blessing, the word nudge,
Yes.
borrowed from the US literature, and which itself actually is worth bearing in mind, has roots in particularly this notion of libertarian paternalism. But therein also lies a partial answer, at least from those origins. So when Richard Thaler and Cass, who particularly pushed the term originally, their point, especially from a kind of US political point of view, if we're honest about it, was that such a thing should be choice enabling. An idea, unlike a conventional sanction where you just say you cannot do this or whatever, because people don't necessarily comply, is that, I mean, the famous example is auto-enrollment. So you try and set the default in a way which would be to the benefit of most people. Or the everyday example is, how do you arrange a canteen? If is a salad or the chips going to come first? And the point would be, if you can relatively easily, if you don't want to do that, you can walk on by the salad. But we know, if we find from various studies, is that you fill most of your plate from the first couple of things you reach in the canteen. You say, well, what would most people think would be a reasonable thing to do based on the evidence, and how we set the tool? And a really important point, I think, in that literature is to understand is that the so-called choice architects is that whether you want to or not, be it you're the head teacher designing the canteen, or you're a policymaker trying to decide the defaults on a pension system, whether you like it or not, there will often be a kind of inherent choice architecture. My own view on it, and I've written quite a bit on it, such as Inside the Nudging, but is that that's not an adequate response. And it is appropriate to say who nudges the nudges. So I've always been very big, for example, on deliberative forums, where you'd actually try and get a group of the public and say, well, if we show you the evidence, what do you think? Where should you set the defaults? And then you also, of course, with technology, have so-called smart defaults now often discussed, which is that, Simon, is the default for you different from the default for me in a smart system, given that we've got other things in our lives to do other than make endless choices about, do you want this or do you want that, or do you want, it's like, for God's sake, can you just get in the right ballpark, but be able to. It is important to bear in mind, I think, that I'm sure Susan would say the same thing, is that behavioral science is more than the use of nudges. They are a particular technique, but they apply in many other domains, even if there isn't that much, choice. So, you can try and work out, be it from the way a medication packet is written, to help people actually understand it, through to many other things, where you can try and say, for actual human beings interacting through the system, what would make it most legible? What would make it most effective, given if we as a society want to achieve the following thing?
So I think on the issue of ethics, you say we as a society, but the society is made up of very, very different groups of people, some who are incredibly powerful and wealthy, and some who are incredibly disadvantaged. And I think the issue with ethics is who decides, because actually most people who are overweight, most people who are smoking, want to lose weight and want to stop smoking, and so would be very up for these kinds of approaches. But I think the key issue is, we know that because we've asked people, because people have been engaged in it. And I think the key thing is engaging the public, and that means all of the public, especially those most disadvantaged, and having proper procedures and forum where there can be joint decision making. So for example, in our current context now, we've got a situation where pubs are open, where we know the dangers in terms of the increased risk of viral transmission when people have a few drinks, when they're in enclosed spaces, been there for several hours, ventilation might be poor, etc., etc. But we've also got a situation where millions of children have been without a school set up, have been damaged as a result of not having the emotional, the social, as well as the educational stimulation. And a question mark, is raised about when they can get back into some kind of collective educational situation. Now, I think if most people in the country were actually consulted to say, do you think it's more important to have a really high certainty of all our children being able to get back to school in early September versus opening up indoor pubs now, I think they would go for the former. But this is an example of ethics where I think the whole public needs to be engaged. There needs to be more partnership, more consultation than there has been. And I think, that's one of the most important dimensions, I think, of ethical policy.
True, but I think if we take opinion polls as an example, we'll find the public is deeply split on many of these issues. It wouldn't just be it would be hard to find consensuses. But that's not what I want to ask. I want you with your collective brilliance to help Jill Stackhouse here. Jill is a clinical caseworker working for NHS Test and Trace, and she says, well, what are your thoughts on she's suggesting that many contacts are very reluctant to take part in the Test and Trace system, and reluctant to do the required behaviours when they are contacted. But what insights have you got to help her?
Well, this is something that has been discussed both on SPI-B and by Independent Sage. And I think if you're asking people to shop on their friends, if you like, and their friends will then be asked to isolate for 2 weeks, that could lose them an enormous amount of money in a situation where it may be very difficult in terms of their accommodation anyway. So you're putting them in a situation where they may feel exceptionally really guilty. You know, a lot of people won't do that. And it goes back to my earlier point. It's not enough just to motivate people. It's not enough just to tell people what to do. You need to be able to give them the social and material context in which they can do it. So if we want people to quarantine for 2 weeks voluntarily because they've been in contact with somebody else, they do need to have financial security. And secondly, how many people in this country have got houses where they can really isolate within their house? Not many. Other countries, for example, Vietnam, who have had no deaths at the last time I heard with COVID, as soon as somebody gets a positive test result, they and their contacts are offered accommodation and looked after for as long as it takes. Now, you know, we are not a poor country compared to Vietnam. If Vietnam can do it, we can do it.
Well, it may not be a poor country at the moment, but who knows what's happening. David, do you want to add something on that to help out?
Yeah, I do. I mean, I don't know exactly what Jill, maybe she's a tier 1 trace or whatever, but the test and trace system is unbelievably important. I think everyone recognizes.
Yep.
You know,
Yeah, absolutely key.
And it's also just, when you unpack it, this is one of these things, is that you realize there's just lots and lots of human behavior in the whole thing. So you're going to, first of all, even get people to take a test in the first place. Would you take a test? There's a significant issue at the moment, particularly with the numbers of asymptomatic, which it seems, I think, early on in the cycle, people were less maybe attuned to. And you've got people who might think, well, I feel a little bit off, but actually, maybe I'll be fine in the morning or a day or two after. And we really need people to come forward and get that test, right? So it's a major issue. And we have to use every channel we can to try and get more people into the funnel. So there's that issue. Then, as Susan was alluding to, then you've got to speak to someone. You know, they may have concerns about it. You know, they may be asked potentially intrusive stuff about who else did you see. There might be other knock-on consequences. Can you remember who you saw? You know, so what kind of memory cues can you use? So as soon as you pick it apart, there's like 100 different elements, all of which you can try and optimize. And the point about a system like this, and it's really important, one which I think medics understand quite deeply, right, is that world class doesn't just get launched on day one. So you have to hone and tune and improve, right? It's which combination, what's the right way of doing this? Is there a better or a worse way of doing it? And then to optimize all aspects of that process. So that includes, of course, yes, certainly for people who may have economic needs, you know, do they have enough support? But often it will be lots of other practical issues as well. And can you solve some of that? And what are the other kind of concerns? Can you take out all of those frictions to kind of create what amounts to world class? So, I mean, the test and trace system has been an incredible achievement in many ways. To have built that level of testing capacity. There's 50-odd thousand people now working in that system on the testing and the tracing side. And it's really important the public also kind of all play a role together on that thing. So it's really important. And I just think there's, as I said, 100 different questions in there about how can we optimize and improve across that whole thing.
Okay, so hopefully there'll be a place where Jill can find the 100 different answers to that. Now, normally I'd stop at this point, but I've so many questions come in, more than I'm used to actually, or than we often get. I'm just going to take 2 more, which will add 5 minutes. So if people want to go for a lunch break, go for a lunch break. But I just want to take just 2 more. So quite a lot of people are asking this. William Davis in the New Statesman last week. What he wrote was, the slow return of liberty is a more contentious process than its removal. Now, that's what we're trying to do at the moment. And just as we know getting the schools open again, it's important. We all agree it is important for the economy to get working, for people to go back to the shops, the restaurants, the workplaces, etc. Equally important in terms of our longer term survival. What behavioral advice or techniques would you now be suggesting be added to get people back into shops, restaurants, the workplace? Well, who wants to start?
No.
Susan.
Okay. Well, first of all, I think it's a very complex issue and needs to be, acknowledged it's a complex issue. There are different people who don't want to go back for different reasons. And this is another example where I think that whatever the sector is that's being discussed, having some kind of community engagement with those sectors, so there's enough planning, there's enough understanding about what people's concerns are, and the strategy is responding to that, rather than very sudden announcements of things without that planning and the preparation, because then people aren't psychologically prepared for engaging. So that's the first thing, I think, planning, preparation, and co-production, alongside the other communities. The second thing I would say is that people need reassurance, and in the current situation, the current strategy, and I have to say, I do have a question mark about what is the UK government strategy. I know what Scotland's strategy is: go for zero COVID. Once you can get zero COVID, then we can open up, the economy can blossom and all the rest of it. And so there's a temporal thing. And I think it's interesting because I think, Scotland and other countries, actually, Ireland and the North too, are going in this direction. If you go for keeping it down and getting it down, and get the test, trace and isolate system where it is functional, I don't think it really is functional yet, certainly not good enough, not a great achievement yet. If you can get that going, then you can jump on the outbreaks, which there will inevitably be as they emerge. But the problem we're now faced with, and the situation over travel to Spain is an example of this, Leicester's an example of this, is because we haven't got it down. We've got thousands of new cases each day still. We haven't got it down to a level where we can have that successful strategy. It means we're faced with a kind of yo-yo situation where we don't know where we are. And uncertainty and lack of control is the thing that's going to keep people being anxious and not wanting to engage. So I would say the main thing we should do is the UK government should follow Scotland's lead and go for a zero COVID strategy, which is what Independent Sage has been advocating also.
Yes, okay. I mean, I wouldn't agree with that, but then I'm just chairing. David.
Sure. So look, it's really interesting. Obviously, you've got a balance between the economic issues and the health issues. I just go back, actually, when the Behavioural Insights Team was formed right back in 2010, there was this phrase from the coalition agreement which was used, which is still kind of relevant, which is to support people to make better choices for themselves. So of course you've got to build a test and trace system and all the rest of it. But one of the important things about more information being out there is to help people calibrate what is the risk for you in your area, to be more aware. When you go into a hospital or a clinical setting, remember nosocomial has been a big issue here. Are the staff, is everyone aware of what's the level of, cases in that location to really remind you, for God's sake, do wear your mask and wash your hands, etc. The same will be true in other settings in relation to the economy particularly. So in some ways, I think as important as test and trace, not as important, but is the so-called COVID secure stuff around businesses. We had a very interesting result in a trial we ran this week, where we were asking people about what will give you the confidence and basically make you go into a restaurant or whatever. And if we give you 10 quid and pay for it, sound familiar? And sure, yeah, it boosts by quite a few percentage points. On the other hand, we did a randomized controlled trial, and one of the things we vary is you see the waiter with or without a mask. When you see the waiter with a mask on and so on, you get a massive 20% pointage increase in the number of people who would then say they would be happy to go to that restaurant. Now that isn't completely mad, right? So when you walk into that location, that shop, is it actually doing the right things in terms of wearing masks, screens, etc.? So it's very important, like, can you get these reinforcing loops that are going? And Simon, if you could see the difference, would you choose at the margin a restaurant or a pub which you thought was more COVID secure versus one was not? And then you start to wind together both the economic effects, the personal behavior, and the health. right? Does that solve the whole thing? Do suppression by itself? No. You start to get your underlying forces going in the same direction, including, by the way, are you collecting details to have an effective test and trace system so that if there is an incident, you can kind of get to everyone in that hub or wherever.
Just one of the things I said right at the beginning was the issue about it's really important to look at people's behavior, what they actually do, not what they say they'll do and their intentions. So, you know, whilst that can give some clue, you know, it's not a certainty that that's what's going to happen.
Yeah, I think that is, and I noticed from some polling, a number of people say they wouldn't go to a mass sporting event again, but it turns out they didn't go to mass sporting events before. Anyway, right, last question. It's got to be short, okay? We've talked a lot about behavior among the public, but what about behavior amongst policymakers? What have you found to be effective in yourselves as behaviors to influence policy? Nudge, fear, data, violence, blackmail, whatever you choose. So turning it on policymakers, what are the behaviors that effectively change them?
Well, I can talk about working with policymakers over the last few decades, and I can talk about working with policymakers over the last couple of months.
Let's say couple of months and quick.
Well, the answer is, I don't know, because, you know, being on SPI B, what we do is we produce papers that go to SAGE, and SAGE then does something with them, they go somewhere else, and we never get any feedback as to what of any of our work has influenced policy. And so I can't answer that question. I can answer the question about the many decades I've spent working with policymakers, but that probably is a whole other conversation. All
right, and
so,
David?
Simon, I hope one of the things, at least that matters, is evidence, right? And we should work really hard to make sure that's the case. SAGE is a representation. As you know, I also serve as National Advisor on what works, which is trying to get more empirical methods. And if you've got nothing else from the behavioural science stuff, it's just use empirical methods wherever you can to optimize and improve, as we see in the test and trace system. So if that's happening, that's actually also, you can see it's characterized in the current spending review and so on. But of course, that's not enough alone, right? One powerful emotional case can cut through. And so effectively, I mean, and remember, policymakers are a very complicated crowd, right? It's not just a prime minister or a minister, it's all the layers in between, let alone what will be done on the front line. And you have to work out, well, what's your theory that's going to reach across all of that kind of activity. And interesting, maybe I'll flag out one thing. We hear a lot about, you know, good and bad, but we did a report a couple of years ago called Behavioural Government, where we worked through this and look at, well, actually, turns out policymakers, including experts, by the way, are also human beings. And the voice in our head, I hate to put it beautifully, I think, around, is essentially a press officer. It tends to rationalise and tell us why the thing or the theory we believe in is most likely to be true. And so you want to really design institutions to keep challenging even experts, in fact, to make sure you're sure, is there another alternative you might have missed? Are you sure you're not over-optimistic? And then you have to set targets and so on. So people like, you know, Matt Hancock may have got a rough ride, but he was right in the end, I think, to have to say on testing, we're going to go for this, what seemed like a crazy target in order to drive the whole system and drag it in all its constituent parts to get there. So yeah, lots there, of course.
It certainly is, but never underestimate the appeal of emotion, I think, as well. So don't go, but let me just round up as we do at the end. So to remind everybody listening that on Thursday, we'll be back at 12:30 again. It's our monthly roundup, so the return of Desert Island Papers, and then a roundup of all the hundreds of unanswered questions, many of which have accumulated today, I'm afraid, and we'll have to come back to. And returning by popular demand, we'll have Peter Openshaw, Martin McKee, and Jill Livingstone there to cover all that. And then tomorrow evening, relax with a glass in your hand, as Ken Follett will be our guest at 7 p.m. in Conversation, dragging you through the eye of a needle as Hilary Lyon tackles him. So we're going to call that to halt, and I just want to thank both David and Susan for a brilliant conversation, actually. And judging by the ticking over going on my iPad, one that, as they say, has raised far more questions than answers, but at least you gave some answers, and no doubt we will continue the questions as this is going to go on for a long time later on in the year, and I'm sure we will have you back. So thank you very, very much, and good afternoon to everybody who is listening, and we'll see you again.
My pleasure.
Thanks, Simon.
Thank you, Simon.
Well done.
Bye.